I've been asked to talk today about the use of intracardiac echocardiography in the cath lab for procedures done in congenital heart disease. And I'm really grateful for this opportunity. I specifically want to thank the organizing committee, including Dr. Balani and Dr. Muralidhar, for this opportunity. So today I would like to focus on the basics of ICE. What are the tools? What are the techniques? How do you navigate the heart? What are the standard ICE echo views? What are the common clinical applications? And I would like to spend the last few minutes talking about comparing ICE versus TE. So let's delve in here. So there are several different kinds of ICE catheters available in the market, but you can largely combine them into two groups. There is the rotational ICE catheters, which we're not going to focus on today. These are the non-steerable kind with very short depth of vision, which are mainly used for looking at the intra-atrial septum. We are going to focus today on the phased array catheters. The two most common kind that are available in the market are the AccuNav and the VFlex Extra. They both are side-looking 64-element phased array catheters with 4-way steerability, and they can do both grayscale and Doppler. So how do these compare with each other? The most common catheter that I have seen used is the AccuNav catheter. It's been there longer than the VFlex Extra. It comes in two sizes, 8 and 10 French. The VFlex Extra comes in 9 French. They are both similar in length and frequency. They're both 64-element phased array catheters with almost similar tissue penetration for all practical purposes. The main difference in my mind is the VFlex Extra has a locking mechanism that's auto, so when you put in a flex or a turn, it just stays in that position, whereas for the AccuNav, you got to manually lock it. They both have 4-way tip deflection, anterior, posterior, right, left. The VFlex Extra, however, has a deflection angle that is up to 160 degrees as compared to 120 degrees for the AccuNav. And AccuNav at least has a 3D version right now, but I'm sure VFlex Extra is not way behind in that regard. So what is the basic difference between navigating a TE versus ICE catheter? I want you to understand that difference today. So in a TE, as you all know, if you want to get different images, we advance the TE probe in and out of the esophagus. We are able to bend the tip anterior, posterior, right and left. But in addition, we are able to rotate the phased array, the piezoelectric crystals, 0 to 180 degree to get all those beautiful angles in which you can cut the heart. In ICE, you cannot rotate the piezoelectric crystals. They are fixed. So the only things you could do with while steering this catheter is, just like in T, you can advance the probe in and out of the body. So from lower right atrium, for example, into the mid right atrium and high right atrium. You can rotate the tip, flex the tip anterior, posterior, left and right. But in addition, you can rotate the whole catheter clock and counter. So that way you can sweep the heart, and I think sweeping is something that you should get used to if you're using the ICE catheter. That is the only way to try to understand the anatomy, especially when we are limited by not having the ability to rotate the phased array system. The other basic difference between ICE and TE is that in TE, you're looking at it from the left atrial side, right? Because the catheter, the closest structure of the heart to the TE probe is the left atrium. Whereas on the ICE, the closest structure, and in fact the structure that your catheter is in the right atrium. So everything is inverted a little bit as compared to TE. So ICE and TE, those are the two basic differences. And if you understand that, it's very easy to navigate the ICE catheter through the heart. The steps of inserting are extremely easy. I generally use a 9 French 25 cm long sheath on the left femoral vein. If I'm working and doing the interventions from the right femoral vein, you hook the catheter to the machine, advance it under flow to the mid-right atrium, and start imaging. So very easy. There are 5 basic positions for the ICE catheter, and the most common positions that you can use the ICE catheter with. And with the use of these 5 positions, you can look at almost everything in the heart, including coronaries. The most common positions that you need to get used to are the lower right atrium and the mid right atrium, which we'll spend a lot of time today on. You can also advance the catheter into the right ventricle and get a beautiful inflow and outflow view that cannot be beaten by any TE imaging. Our structural heart disease colleagues have specialized the use of ICE catheter in the left atrium to help them with left-sided interventions, which has been revolutionized over the last decade, not just the left atrial appendage, but also mitral valve interventions. So let's spend a little bit about the basic positions with the ICE catheter. Everybody should be familiar with the home view. That's where you start with imaging of the heart. And if you get lost somewhere, for example, the catheter falls into the hepatic veins after you put a big posterior tilt, you unflex the catheter and you always start back with the home view. In home view, which is the view you obtain when you advance the catheter to the mid-right atrium and you turn it anteriorly, there is no need for any flexion. This is what you see. You see right atrium where the catheter is. You see a beautiful view of the tricuspid valve. You see the right ventricle, the aorta and the PAs are to the side here. That is the home view. From here, all you got to do to image the entire heart is to lock it in position and then you rotate the whole catheter clockwise away from you. And as you do that, the catheter is going to sweep the entire heart, and I will show it to you in the next few slides. So if you clock a little bit, the next structure that you can see is the aorta and the RVOT as shown here. So the PA is the most anterior structure away from the ICE probe here, and the aorta is between the right atrium and the pulmonary artery. And if you rotate it even further just a little bit, you can get a beautiful view of the aortic valve, just like this. So no flexion, just keeping the catheter in the mid-right atrium and rotating it away from you from the home view. If you keep continuing with the theme here, if you keep rotating it, the next structure that you will see is the intra-atrial septum, and from there you can see the mitral valve. So this is the intra-atrial septum. Your catheter in the RA. Across the intra-atrial septum you see the left atrium. You can see the left atrial appendage here to the side, mitral valve and the left ventricle. As you continue to rotate, the next structure that you will see are the left pulmonary veins. Remember, the left atrial appendage is an anterior structure. As you go more posterior, now you are starting to see the left pulmonary veins coming in, as shown in one of my patients here who's there for AST closure. And if you continue rotating, sometimes you see the aorta between the left veins and the right veins. You can even see the esophagus sometimes right next to the aorta. Keeping with the theme, if you keep clocking away from you, you will then end up looking at the right pulmonary veins. It's not very difficult to get the right upper and the right lower pulmonary veins just like this in any patient, just by rotating the catheter. Sometimes you might have to advance it a little bit so as to center the pulmonary veins. So as I showed, just by rotating the catheter away from you from the home view, you can see a lot of the heart right there. And I generally come back to the left atrial appendage or the mitral valve view, and if I want to look at the intra-atrial septum a little bit more in detail, I put a nice posterior tilt, and as you do that, the catheter itself moves away from the septum and you will be able to look at the intra-atrial septum better. If you want to advance the catheter into the right ventricle, again you start with the home view, you do a nice anterior flexion and you advance it under echocardiographic and fluoroscopic guidance into the RV, and then as you clock it up, you will be able to get a beautiful right RVOT pulmonary valve MPA view as shown in this picture. In the interest of time, let me proceed with discussing the clinical applications right now before I spend a little bit of time on AST-PFO closures. So in my mind, ICE is used either for interventions, which is the majority of the time, and sometimes even for diagnostic imaging. And I prefer to use ICE over TE, especially when I'm trying to look for vegetations on pulmonary valve, especially if they are inside a biprosthetic valve or a stented valve, where TE may not be very useful. ICE is very useful in separating out clot versus vegetation. It can show us the valve anatomy. It is especially useful in understanding whether any leakage is central valvular insufficiency or perivalvular in nature, especially useful in understanding the perivalvular leak anatomy if they are anterior, where TE may not be the best. It's also superior to TE in imaging the IVC septum. The most common use of ICE, however, is in atrial septal interventions, including AST-PFO closure and transeptal punctures. And our structural heart disease colleagues have revolutionized the use of ICE in left heart interventions, including interventions on the mitral and the left atrial appendage. It is extremely useful not just in helping with transeptal puncture part of the procedure, but also in assessing balloon positioning or device positioning and looking for complications such as pericardial effusion and MR, etc. ICE has been a part of a lot of pulmonary valve interventions these days, as I discussed earlier, and our EP colleagues use them in a variety of procedures, not just in doing transeptals, but also in guiding ventricular arrhythmia ablations, trying to point that ablation catheter on the moderator band, for example, or identifying the pulmonary veins so that they don't inadvertently ablate the pulmonary veins during AF ablation. Let's talk a little bit about ICE in AST and PFO closure. Just like any other imaging used for guiding these procedures, eyes will help us in identifying the anatomy, in making sure there is just one hole and not multiple holes, identifying the size of the defect and its locations, in identifying the rims. It can guide us in balloon sizing, guide us during device placement, and then it will help us assess proper device position and identifying any residual defects. And I will show you a few examples. So I talked to you about how we get back to the left atrial appendage mitral valve, do a nice posterior tilt, and you will be able to see the interatrial septum. But as I discussed, you cannot rotate the eyes, the phased array system like in TE. So the way to assess the entire septum, especially looking for rims, is to do a sweep. And we can do the sweep after the posterior tilt. You got to rotate the left and the right knobs. And as you rotate rightward, you go towards the SVC, and you can see the interatrial septum and the SVC coming in. If you rotate it leftward, you come to the aortic valve and you get a beautiful short axis view looking at the interatrial septum towards the aortic valve. So just by sweeping the catheter from the aortic valve to the SVC, you can see the entire septum and understand all the rims that you need to understand about any defect. This is a real-life example of one of my patients showing us the sweep. As we discussed here, my eyes catheter is rotated rightward and you are seeing the SVC coming in. You don't see any atrial septal defect in this position, but as I rotate it counterclock or leftward towards the aorta, you start seeing the large atrial septal defect here. And once again, as you reach the aorta, the atrial septal defect is barely there. But that sweep helps us look at the SVC rim, IVC rim, aortic rim, and posterior rim, all in just one big sweep. The biggest strength of eyes is in imaging the IVC and the posterior part of the septum, as shown in one of my adult patients where there was barely a IVC and the posterior rim. As I'm doing the sweep, at one point you don't see any defect, and when you start seeing the defect, there is barely any IVC and posterior rim. This kind of ASTs are very difficult to close in the cath lab, and I think we sent him to surgery. This is another example of an adult patient that was referred to us for PFO closure in the setting of stroke. You can see here how beautifully the eyes is showing us an aneurysmal septum with multiple defects, one more anterior towards the aorta and one more posterior towards the posterior septum. We were able to close both of them with two separate devices. I generally use balloon sizing for my PFO closures, and this is just an example of an index patient that we close the PFO using ICE guidance. You can see the eyes here on fluoroscopy with a nice posterior tilt, looking at the balloon across the interatrial septum with a nice waist. ICE can show us the waist and make sure we are doing a proper stop flow technique, and ICE can help us assess the defect after device closure. In this case, we closed it with the Gore cardioform septal occluder. Similarly, ICE can be very useful in AST closures as well. Everything is similar. Whether it be Amplatzer device or a Gore device, ICE can give us beautiful images as shown here. Our EP colleagues use it more often for creating a hole rather than closing the hole in the atrial septum, as shown here in this picture. ICE can guide us in the proper location of the tenting of the needle. It can guide us in the thin part of the septum. It can show us once the sheath is crossed, and it's extremely valuable in EP procedures as well as in structural heart disease interventions. For us in pediatrics, ICE has revolutionized the assessment of the pulmonary valve after pulmonary valve implantation by putting the catheter inside the right ventricle and looking up. On FOSS, you do not have the stent artifact, and you can just look at the leaflets of the pulmonary valve without the stent in between, and it can show us nicely, as shown in this example, if there is any insufficiency, whether it is central or perivalvular. It can guide us whether there are any vegetations on the leaflets, etc. ICE has been described in use of VST closures. It has been used extensively in the use of perivalvular leak closures, as shown in one of my patients here, especially in the anterior perivalvular leaks where TE may not show us well. ICE is extremely helpful. So how does ICE compare in relation to TE? The major advantage of ICE is that you don't need general anesthesia. So you can do it with sedation. You don't need any other cardiologist. You can do it all by yourself. Studies have shown that it takes less time and can be easily integrated in your cath lab system. TE, however, has made a lot of advances in advanced imaging, especially 3D TE. ICE is still catching up. TE has been known to have low complications, and the cost is reasonable for TE because you can reuse the probe. However, that cost may be offset because you need general anesthesia. If you look at the national data between 2003 and 2014 and trying to compare ICE versus TE for AST device closure, ICE has definitely taken a fair chunk of the volume from TE, and almost 50% of the AST closures in the United States in 2014 were now done with ICE. And in this really nicely done research looking at national inpatient data comparing propensity matched patients, about 1600 patients between ICE and TE, it showed that ICE closure was associated with less complications, shorter length of stay, and the cost was not a prohibiting factor as well. So in summary, ICE is increasing in popularity. There is an operator's learning curve that exists, but we as cardiologists need to get familiar with ICE so that we can expand our toolkit in the cath lab. ICE has to keep pace with TE advances. Improving its weaving depth and 3D are extremely important so that it can compete with TE. Although there is a paucity of safety and efficacy data in congenital heart disease, I believe there is more data coming, and ICE is definitely as safe as TE and has a lot of advantages. These are the references for any of you that are interested.